All right. So in this particular discussion, we are going to look at
All right, so in this particular discussion, we're going to look at disorders of the esophagus. In the other discussion, we looked at the disorders of the mouth. So first things first, we know that the esophagus is a muscular tube that connects the oral cavity to the stomach. Now, this tube has layers. So from the inside layer, we have the mucosa, all right? If I can use this diagram just for, so that is the esophagus at the back there. In front is a trachea. So this arrangement, trachea is always in front or anterior. Then posterior to the trachea is the esophagus. Now this tube has layers. So the innermost layer inside there is a mucosa made up of stratified squamous epithelium. So that's a protective epithelium because mainly this organ transmits food that has just been primarily processed by the mouth. So to prevent damage, friction, and so on, it's made up of that epithelium. Then the next layer going out is the submucosa, which is a layer of connective tissue. Now, special to this epithelium is that in the submucosa, the esophagus has glands. So there are mucus glands found in the submucosa, which you can see here. And those mucus glands produce mucus that offers some sort of lubrication as food substance is passing through the esophagus. Then the third layer will be the muscle, which you can see here on the surface, muscle layer. So there are two layers of muscle, inner circular muscles and outer longitudinal muscles. So circular muscles go around the tube. Longitudinal muscles are vertical. Then, of course, it's covered by an outer covering of connective tissue called adventitia. So those are the layers of the esophagus. Now, let's look at some of the disorders that are associated with the esophagus, starting with the tracheoesophageal fistula. So fistula is a connection or abnormal communication between two tubes of the body. So we're talking about the trachea as well as the esophagus. So tracheoesophageal fistula. Now, during embryology or development of the human body, especially in the third week is, when the embryo or those two layers of the fertilized, cell turn into an embryo. So we call it embryogenesis, all right? The cells, that mass of cell is now being transformed into an embryo. So the esophagus develops together with the trachea. So it is, first of all, one tube, then that tube develops some ridge. Okay, so this ridge, you can see that ridge, another ridge here, or diverticulum, if you like. So this ridge or septum, sorry, not diverticulum, septum. So that ridge or septum is going to divide. So initially it is a single tube, but that septum develops. So anteriorly will be the trachea, the one shaded in blue. Then posteriorly will be the esophagus. So this is a future trachea. Then you can see there the respective diverticulum. This structure later on develops into the lungs. So our focus is on the esophagus. Now, this continues, so the ridge continues to emerge from either side until there's complete separation between the trachea in front and the esophagus at the bottom, at the back there. Now, tracheoesophageal fistula comes in when there is incomplete separation or closure of these two ridges so that the trachea is independent from the esophagus. So there remains now those two communication. So that is, congenital defects. And there are various reasons why such may occur, exposure to certain medication, genes, drugs, and so on. that may interfere with the processes of embryology. In some instances, again, a fistula between the trachea and the esophagus can be created during procedures that has to do with the trachea or the esophagus, during endoscopic visualization of either the trachea or the esophagus, or indeed maybe during performance of the tracheostomy, and then there's iatrogenic injury to the esophagus leading into that connection between the esophagus and the trachea. So that fistula can be there congenitally, person is born like that, or it can be created artificially during accident or traumas. Those accidents we're talking about surgical accidents. All right. So there are different types of tracheoesophageal, fistula, as you can see here. So you can see that the esophagus is not complete. It's split in half. One of the portion of the esophagus, of course, connected to the trachea, and another one at the bottom there. So we got that a double fistula, or fistula without esophageal atresia. So in this case, there's esophageal atresia, where there's no connection between the esophagus and the stomach. So food content will not reach the stomach. Okay. Then we have another effect here where there's esophageal atresia, but no fistula. So this is a complete esophageal atresia, where there's no communication between the upper and lower part of the esophagus. So food content, when eaten, will not reach the stomach. All right. Now, so these are the causes. So clinical presentation, how will you know that this? Usually they are diagnosed in childhood, because when a human being is born, usually we expect them to feed, and you see that in this instance, food may go into the respiratory tract and accompanied by choking, vomiting, and so on. Or they will be coughing as some of the food content pass into the respiratory tract. So in this case, some of the food will reach the lower or the stomach, then some may actually enter the respiratory tract. So that's a fistula there, a fistula, and another fistula. Even here, there's a tracheoesophageal fistula. So how are these problems corrected? Mainly is by surgery. So we must make sure that this connection is obliterated, and then the esophagus is anastomosed, so that there's proper channeling of food from the mouth into the esophagus all the way into the stomach. Okay, so most of these tracheoesophageal fistulas occur congenitally, okay, when the processes of development go amiss due to various, reasons. So they fall under what we call congenital disorders. Okay, so mainly it's surgery, correction of the fistula, and anastomosis. Now, when fistulas are discovered, mainly you find that other investigations has to be done. We have to check. Usually patients with such problems who have, craniofacial disorders. So disorders on the face. So child may have a cleft lip, or a cleft palate, or indeed some deformities around the face, or deformities around the cranium, where there is distortion in the shape of the cranium. Next area that will be assessed is a spinal column. So you may find such a baby may have a kyphosis, a scoliosis, lordosis, and other spinal vertebral disorders. Then the other areas that you must examine is now to check for other, internal organs. So the kidney has to be assessed. You may find that this individual or child only has one kidney. The other one is underdeveloped kidney or renal agenesis. Doesn't grow to full size. Liver also has to be checked. You may find that liver is incomplete in terms of development, also called liver or hepatic agenesis. Then the other areas that has to be assessed are limbs. All right, limbs, the upper and lower limb. So we call that assessment as factor L. Okay, I'll write it here so that we can all be together. So factor air. So these are the areas that you have to check. So you have to check the vertebral column, that's number one. Next, check the cardiovascular system. So VA, vertebral column. C, cardiovascular system. T is trachea. E, esophagus. Then R stands for the respiratory system. Then L stands for limbs. So vector L. Okay, like that. So it has to be assessed. Okay, so patients with disorders of the esophagus, make sure you check for vector L. We look at the esophageal atresia, which is presented in the same diagram here. So esophageal atresia, we find this underdeveloped esophagus. So the esophagus ends in the blind pouch like that. So again, diagnosed in early days of life when the baby is born. So this child, when they suck milk, of course, it collects in this pouch, but this pouch fills faster because it's smaller than the stomach. So with the next feeding, you see the child is vomiting everything. Every time the child feeds, vomits, feeds, vomits. And they're at a higher risk of aspiration because once they vomit, chances are that they might actually aspirate such vomiters into the trachea and cause other complications. So it's quite a common disorder found in newborn babies. About 1 in 4,000 may have such a problem. So patients or babies usually present with excessive drooling, coughing, and choking following feeding, and the child may become cyanotic. Of course, that indicates obstruction of the respiratory tract. So this child has to be fed otherwise parenterally until that problem is corrected. So all we need is an anastomosis, that blind spot connected to the lower part of the esophagus, and then food will be channeled into the right path. So all that are congenital abnormalities. Okay, rarely happens in surgery where, unless there's really cancer where the rest of the part of the digestive system is cut off, but these are congenital defects diagnosed in newborn babies. So, esophageal atresia may occur with accompanied tracheoesophageal fistula. So you see there's an atresia here, or when the remaining part of the esophagus can be connected to the trachea, or indeed just atresia without tracheoesophageal fistula. Here is an atresia, but there is a connection there. So esophageal atresia occurs with or without tracheoesophageal fistula. So of course, history must be taken. Of course, if at all this woman has delivered such kind of a baby before. Physical examination, you assess those signs and symptoms we've mentioned. Child vomiting everything every time they are fed. Then a barium swallow or meal can be administered, then followed with an X-ray to identify that problem. Usually this is a confirmatory diagnosis because you'll be able to see a sac on an X-ray film that has no connection with the lower part of the esophagus. So the only part that will be stained is here because the barium meal or swallow stains the lumen of the esophagus. Then you see that the barium only ends there, meaning it didn't reach the stomach, or it may end here, meaning that's where the pouch or the esophagus is closed. Okay, treatment, of course, is surgery, reconnection of the esophagus, or anastomosis to the lower segment of the esophagus, of course, followed by appropriate nursing care. Complications, mainly we are worried with aspiration pneumonia, which can lead to obstruction and death if not managed effectively. So some of those content, milk, and other products the baby can aspirate and cause obstruction. Achalasia, we're talking about spasms in the lower esophageal sphincter. Now, the lower esophageal sphincter is somewhere here, there. Lower esophageal sphincter. Now, the lower esophageal sphincter is not really an anatomical sphincter. It is a physiological sphincter because of the position and location of this esophagus in relation to the stomach. So we find that muscles in that lower part of the esophagus undergo spasms and prevent food that has been swallowed to reach the stomach. That's when this problem comes in. So it is mainly a neuromuscular disorder where there is improper coordination between the vagus nerve and the smooth muscles of the lower part of the esophagus. And needless to mention, say the upper part of the esophagus is skeletal, whereas the lower part of the esophagus is smooth muscle. So we have no control over those, muscles. So patients have difficulties in swallowing, often vomiting, regurgitation, coughing, and pain accompanied after feeding. Diagnosis more or less the same. You still need a barium swallow followed by X-ray or endoscopic examination. Rarely, esophageal manometry is done to ascertain the contractility of the muscles in the lower part of the esophagus. But histophysical exam plus barium swallow, that would be enough, or by endoscopy, that would be enough to come up with diagnosis. So management, of course, commonly is myotomy, incising some, vertical incision into the muscles of the lower part of the esophagus to relax them, or severing certain branches of the esophagus so that those muscles become relaxed, allowing food to enter the stomach. Okay, in some cases, these are rarely done, but nitroglycerin and calcium channel blockers, which causes muscle relaxation, can be given to the patient while waiting an operation. Another disorder that I want to talk about is called esophageal diverticulum. Now, a diverticulum is an out pouch of a tube, all right? So the esophagus is a tube. So you may find that certain areas of the esophagus may be weakened, and then they cause more like a balloon to form in those areas. Now, there's an area where the pharynx is connected to the esophagus, okay? We have the cricopharyngeal muscle. That's a cricoid muscle. Then the pharynx is somewhere up. So that's a cricothyroid muscle. That's a cricoid cartilage, thyroid cartilage, cricoid cartilage. So this muscle coming from the cricoid cartilage is called cricopharyngeal muscle. Now, where this muscle crosses going to that side, and then the esophagus, the origin of the esophagus is where the pharynx ends here. Same level, that's where the esophagus begins from. So there's a small space, a weakness that has been noted where it is a common site for diverticuli. So as a patient or a person is swallowing food, there's a chance that if there's increased pressure in the pharynx, swallowing food rapidly or a huge bolus of food, because of that natural weakness that all of us have, where these two muscles overlap, there's a chance that some food stuff may create a balloon in that area and create a fistula called Zenker's diverticulum. It is actually a esophageal fistula. There are other types of esophageal diverticula, sorry. So we have those that are found in the mid part of the esophagus and those that are found just above the diaphragm. Okay, we call them the epiphrenic diverticulum. So epiphrenic just above the diaphragm. Then the mid part of the esophagus, we call them mid-esophageal fistula. Then Zenker's is at the point where the esophagus is connected to the pharynx. Remember, the pharynx is divided in those parts: nasopharynx, oropharynx, and laryngopharynx. So this problem can be acquired or patient is born with. So this is epiphrenic diverticular Zenkas, where the esophagus is connected to the pharynx. Then you also have the mid, or otherwise known as traction diverticulum. Okay. So management, mainly if it is not causing problems, the patient, of course, it can be delayed, but surgery serves as a best corrective measure. So patients usually have regurgitation of food content, especially for epiphrenic, throat irritation, difficulty in swallowing, or obstruction of the esophagus because of that growing mass, especially when food accumulates there, that serves as a problem to patient in swallowing. So of course, diagnosis is similar. Barium swallow followed with X-ray, physical examination, and endoscopic examination. So that's a esophagus. So because of this outpouch that has created, so you see most of the barium meal or swallow went into that outpouch. Then this is a continuation of the esophagus. So management is irrigation and excision of that diverticulum. Okay. Dysphagia, this is difficult swallowing. Of course, this is a sign of most of these problems we're talking about. We'll talk about esophageal varices. Now, esophageal varices most usually occurs in the lower segment of the esophagus. Okay, because of the anastomosis that is created by the circulatory system. So this is mainly a complication of portal hypertension. All right. So remember, the portal vein goes into the um, liver, and then we have the hepatic vein that goes into the inferior vena cava. So in patients who have liver cirrhosis, the liver hardens. So blood flow through the liver back into the inferior vena cava becomes problematic. So blood flows back where it came from, back to the digestive system. Now there are other routes that blood can take back to the heart. So there are veins around the neck, veins around the esophagus here, that serves as a point of connection between the portal vein, which is shown here, and the esophageal veins. So if there's pressure, the liver is somewhere here. Blood can't pass through the liver because it's hardening. This patient has liver cirrhosis. So blood flows back. This one is going to the digestive system, to the intestines. Then this is going to the veins of the stomach and the esophagus. So these veins swell. They become bigger and cause such problems called varices. So this is an intervention that was put across a band, rubber band is put or tied around that diverticulum of varices, and then is ligated like that. Then eventually after ischemia, then that part falls off. That's one of the treatment modalities. So you see this in patients with liver cirrhosis, especially individuals who have chronic alcoholism. So you see such problems. Again, veins on the surface of the skin. This is known as caput medusae. So it's a significant sign and symptom of liver cirrhosis. So more like like spider-like web veins on the surface of the skin around the umbilicus. So this patient has portal hypertension. Now, these veins sometimes rupture and causes bleeding. So patients usually present with, hematemesis, vomiting blood, difficulty in swallowing, and throat irritation. Now, depending on the size of if it's just a smaller branch that has ruptured, of course, the bleeding eventually stops. But if it's a bigger one, that becomes a problem. Patient may die from internal hemorrhage. Okay, so when the patient is vomiting blood, such must be one of the conditions that must be ruled out. Okay, so here a ligature is being used to tie off those outpouching of veins. So a varice is similar to a diverticulum, except it's happening in smaller veins or blood vessels. Then finally, we have what we call esophageal cancer. Now, esophageal cancers, these are malignancies associated with the esophagus. Now, I mentioned the layers. So that is the mucosa. This is a submucosa. Then we have the two layers of muscle, circular muscle, longitudinal muscle. Now, I said in the submucosa, that's where you find glands, the mucus-producing glands of the esophagus. Then the mucosa itself is stratified squamous epithelium. So that tube was cut here, and then we are seeing it from there. Now, two types of esophageal cancer are known. The first one is squamous cell esophageal cancer. So this is esophageal cancer originating from the mucosa itself, these stratified squamous cells. That's where the cancer is starting from. Okay. Then we also have what we call the esophageal adenocarcinoma. So it is now an esophageal cancer arising from the gland. Those cells are columnar cells. So that's where they say the cancer is starting from. So two types, adenocarcinoma and squamous cell carcinoma of the esophagus. Now, cancer of the esophagus mainly associated with so many things, smoking, repeated regurgitation, people who have repeated heartburns and so on and so forth are at a higher risk of developing such, problems. So difficult swallowing, painful swallowing, obstruction, depending if the cells are growing into the lumen, like these cells, they may obstruct the tube of the esophagus and cause serious problems for the patient. Vomiting blood, weight loss, because eating and feeding becomes problematic. So this patient loses weight. Of course, there are various predisposing factors. Obesity, of course, highly associated with reflux disease. Then history of cancer in the family, sex, more common in males because of poor eating habits and so on. They are the ones most prone to regurgitations and so on. Human papilloma virus, so infection of the upper respiratory tract, infection of the esophagus with viral infection, mainly with the advent of, oral sex and so on, may cause change in the cell arrangement of the esophagus, turning those squamous cells into other type of cells, causing cancers. Of course, management is three modalities. So first of all, looking at the nature, location, and severity, surgery is considered, where that part where the cancer is removed and then anastomosis is made. Or we can go for chemotherapy combined with radio. So any two, surgery with radiation or surgery with chemotherapy. Of course, plus other complications. So we end here for today. So next discussion, we'll look at disorders of the stomach.